transplant programs. Dr. Shahid then joined the Levine Cancer Institute Carolinas Healthcare as their medical director of the BMT-ID program in 2013 and started a robust clinical transplant ID program with an emphasis on evidence-based practices and host-specific risk factors. And most recently, she has joined Memorial Sloan Kettering as an associate attending in the infectious diseases service, where she continues to care for patients receiving hematopoietic transplant, cellular therapy, and other novel therapies. And she will be speaking to us today about immunizations in this patient population. So thank you so much for joining us.
Thank you, everybody. Thank you for the kind introduction, Samantha. It is my honor and pleasure to be joining this esteemed group and presenting today. I will get started if everybody is ready. I will share my screen and get started. I would like this to be a very much interactive session, so please stop. As you know, that the area doesn't have a whole lot of data, so I think it is a great topic to discuss and perhaps bounce off some thoughts as to how to best care for these patients. So I will go ahead, and I'm unable to share my screen. So if somebody can allow me to share my screen.
Could you please retry?
Sure. Here we go. Got it. So you guys can see this okay?
Yep.
Okay. And I'm unable to hold on. Sorry, guys. Something happened. So bear with me. I'm gonna stop sharing it and then bring my presentation out. Here we go. Let's see how this goes. Okay. All right, let's get started. So we are discussing immunization strategies for patients who receive CAR-T therapy. On the right bottom is my Twitter handle, so I hope to see you guys there. As you know, I don't have any disclosures. I am new to New York City, and this is what my life looks like. I am relocating from the Southeast, so it's definitely a change for me. So thank you for your warm welcome. Let's get started about the mechanism of actions for patients who receive CAR-T therapy. As you know, that CAR-T is a way of obtaining T cells from the recipients and putting a small receptor on the surface of those T cells, which are looks like an antibody. So it is part of the surface antigen of the T cells, and then the protruding portion of the antibody attaches to the antigen on the tumor cells. And depending on the malignancy that we're targeting, that tumor target, the tumor antigen can be, for the purposes of our talk, could be CD19 for lymphoid malignancy, or BCMA, which is also present on B cell for multiple myeloma or plasma cell malignancies. So because of that action, the attachment, the T cells are activated, and we see tumor cell death. And so that's the mechanism that they proliferate in the body and continue to kill tumor cells. The reason we get involved as infectious diseases physicians is because of the toxicities seen with CAR-T therapy. Which is on the right lower bottom is what you see, what we call as on target and off tumor, meaning the CD19 or the BCMA cells, which is present in non-cancer cells, is also going to be suppressed. So all those cells, which are not tumor cells, but normal B cells, are also immunosuppressed. So that's why we see long long-lasting adverse events, which we will discuss, and vaccines or infections become important for these patients. So why to vaccinate? Are these patients living long enough for us to be able to offer them vaccines? And the data suggests that I'll just quote a NIH study, which was published in 2022, where they did a long-term follow-up, and the more than 3-year response rate for their trial for the lymphoma malignancy was 51%, and the median survival was 55% for these patients. So these patients are living long after these interventions. And same is true for BCMA CAR-T, although we have to still see the real world data that has been presented for BCMA CAR-T is mostly limited to clinical trials. So now the next question becomes, are they really experiencing infections that we can prevent by means of vaccines? What are those vaccines which are needed? Do they actually work in these patients? And when is the best time to give them? And the most, million-dollar question, do we make improvement in infectious morbidity and mortality in the setting of CAR-T therapy? So I will just present, and the focus of my talk is looking at later infections. We know that they get a lot of infections within the first 30 days and 60 days, but the focus is going to be what is the incidence of infection 180 days and beyond, so we can see, are these infections related to any of the vaccines that we can give and prevent these infections from occurring. So this is MSK data for diffuse large B-cell lymphoma in 60 patients. And they saw that infections were more common within the first 60 days. So that is their cumulative incidence of infection, which is about 63% in diffuse large B-cell lymphoma patients. And they also saw that patients with low immunoglobulins had higher risk of viral infection post-CAR-T. But what is important is for us to see what was the distribution of these infections. These infections were mostly for bacterial, about 57.2% at 1 year, and viral infections were about 44.7%, and fungal infections were only 4%. Importantly, they did not see any association between infection and mortality risk in this patient population. So again, similarly, this is Seattle experience. So they looked at late adverse events that could occur in patients who receive CD19 CAR. And they looked at patients who had, they defined late adverse events as starting or persistent beyond 90 days after CAR T-cell infusion. Their median follow-up was about 28 months. And these patients were included part of the clinical trial. So 2 important late adverse events were seen. Number 1, hypogammaglobulinemia, and that was the most common adverse events seen in these patients, which is pertinent for us. And then also infection density, which was not too high. They concluded that the infection density of 0.55 per infection per 100 days at risk, which is about 2 infections per patient per year, was not very high for CAR-T patients. And so what were those infections? They were mostly, they could evaluate only 54 patients, of which 33 had infections. Most of these infections were upper respiratory tract infection, mostly upper or some lower. 80% of these infections were treated as an outpatient. 20 were admitted to the hospital. Of those, 5% went to the ICU. Most of these are, as you can see, the distribution on the right top corner of the of this slide here. They were bacterial, followed by viral, and then fungal. And they saw some Aspergillus, Candida, and Coccidio in this patient population, which can be seen, but I don't think that they're very common in these patient population. So this is another paper. This is Moffitt's experience. And so the reason to look at this paper is 2. This is also a retrospective analysis of about 85 patients who were in remission with a median follow-up of about a year. But again, they had follow-up beyond. And if you look at the right, this 0.63 and 0.26 infection density, you can see that it is quite low. They did see hypo. So in other than the infection, what I'm going to switch gears a little bit is looking at immune reconstitution in these patients, because that is directly related to their infection risk, and to see if these vaccines can be utilized in these patient population. So they saw that the CD4 count was low, with a median of about 155 cells per ml at 1 year. And immunoglobulins reached a nadir at about 6 months. And the infection density later on was low. They did not report any deaths with infections beyond day 30. And they made another observation that there was no difference between the counts of CD4 counts in the patients who got infections versus not, but they wanted to look further into that. Now, this is Stanford experience. 2 things I will point out again, same thing, longer follow-up beyond 1 year, about 41 patients in CD19 CARs. But if you look at the infections, again, same, the infections are mostly bacterial or viral here beyond day 180. And only 40% of the patients in this group had a CD4 count, which was CD19 that was detectable, meaning they did have B-cell aplasia that we'll discuss in the next slide. They did comment, however, that certain patients in their patient population had PJP and varicella zoster infection after 18 months because the prophylaxis had been stopped. And the risk factors here for infection was steroids. But most importantly, this is the most important slide that I would like for you to pay attention to, that the CD4 count for these patients by 18 months was 150. So same what we saw year 1, 6 months added, it really didn't see a big rise in the CD4 count. So they still remain quite T-cell depleted as well. And also the T-cell depletion also correlates with B-cell aplasia. So you not only have hypogammaglobulinemia, but also you have T-cell low CD4 counts as well. Similarly, 44% of the patient had not recovered their immunoglobulins by 18 months. And not everybody required IVIG replacement. So the recovery of immune system in CD19 CARs is prolonged. Now, there's not a whole lot of data till recently that has been presented for BCMA CAR, which is for multiple myeloma. This is ASH 2022, Sender Juggernaut's group at Mount Sinai. They just reported retrospectively looking at 82 of their patients who were treated for BCMA CAR T. And in Mount Sinai, they give immunoglobulins for the first 6 months post BCMA. So when they looked at immune reconstitution in terms of B cell, they did not look at IgG, but they looked at IgA and IgM. They also looked at T cell subsets, NK cells in these time intervals. So what they recognized that the median time to recovery for IgA was 30+ months and for IgM was 24 months. So 2 years and beyond. And at the same time, at 2-year mark line, you'd see that CD3 and B cells were still depleted. 1/3 of the patient did not have it. So as you can see in this graph, this is what we would look at. This is NK cells in turquoise, or whatever color you think it is. CD8, followed by B cells in pink CD3s, and then CD4s. So you can see that their immune reconstitution is quite significantly delayed. Because B cells and T cells again. So what we have concluded thus far that number 1, bacterial and viral infections are the ones that occur 6 months and beyond. Most of these infections are sinopulmonary infections, and their immune reconstitution, whether it is CD19 or BCMA CAR, are delayed. So let's look at, after this lymphodepletion that they receive, what is left? So this is MSK data. So what they looked at to see what is preserved after CAR T. This is CD19 CAR, and they looked at patient who had some titers of the vaccine preventable infections in baseline, and they did a titer at year 1. They did not take into account, so none of these patients received immunoglobulins. And so these are commercial CARs. Nobody has relapse or progression of disease. And as you can see, the percent positivity or percent who retained immunity for H influenza, 57%, pneumococcal, 0, polio, 100%, tetanus, 95%, diphtheria, 95%, pertussis, and hepatitis B in the 50s. On the right side, you see the people who got the transplant, because people receive post-transplant vaccines. So they wanted to divide the patients who received the transplant and who didn't. As you can see, there's not a whole lot of difference. So we really don't differentiate patients when we post CAR T to decide on the vaccine based on their transplant status. This is ASH 2021. So there is so much data about SARS-CoV-2 infection and spike antibody protein, but not a lot of data to look at what is preserved. These are two good good summary of 2 abstracts actually that were presented at ASH. Again, you can see the number of patients in each individual group. BCA numbers are very small, for example, 4 in this patient population. And they looked at preserved serology, this one at 6 months, 3 months, and this one at 6 months. And again, the theme is the same. You see low preserved serology for pneumococcus, pertussis, Haemophilus, hepatitis A and B. Here they reported mumps, but hasn't been seen other places. The rest of them are still decent. So you can see that the theme is repeating itself in the reports that is available, that are available. And this is a very nice prospective study from Seattle. Joshua Hill and the group looked at patients prospectively for CD19 and BCMA CAR beyond 6 months. They collected 1 sample, and median time to collect the sample was 20 months. They excluded the patient who could obtain, who received IVIG, so they could only evaluate 30 adults. And they looked at the preserved serologies and divided them by the type of CAR T therapy they received. As you can see that orange is BCMA and CD19 is CD19 CARs. You can see that there is less number of patients with preserved serology with BCMA. So they concluded that compared to CD19 CAR, BCMA CARs were half as likely to have seroprotection from vaccine preventable infections. And they had fewer pathogen-specific epitopes as well. So what we can see that in BCMA CAR T patients, perhaps there is more depth or severity of hypogammaglobulinemia as well. So there are some differences between the 2 interventions. Any questions so far? So based on this, we concluded that the pathogens of interest are the ones listed here. Influenza, obviously, because that is a seasonal vaccine, hepatitis A and B, pneumococcus, pertussis, Haemophilus influenza, and obviously SARS-CoV-2, and perhaps RSV will come in the picture later on. So these are the vaccines of interest. So let's look at how do people respond to these vaccines if given. So all the data that I'm going to present is going to be response to SARS-CoV-2 vaccine, because there are no prospective, nicely done studies that look at responses in CAR T patients for these vaccines, which are listed here. So as you can know, as you know, that there is so much data right now, 5 patients, 2 patients, 10 patients, about serologies after SARS-CoV-2 vaccine and CAR T. So rather than doing individual studies, I just wanted to present this Chinese pooled analysis to look at the serological response rates of SARS-CoV-2 in CAR T patients. And as you can see that this here on the left side, these are the total number of patients, and these are the responders. And then the pooled response rate based on the threshold was 39.5% in CAR T patients. There are about 44 studies here in 172 CAR T patients. So this is the overall response rate for SARS-CoV-2 in CAR T patients. So it's not zero, it's there. And we do know that by our clinical experience as well, that it did decrease the severity of infection. Also, I mean, we know that it's not alone. We had antibodies, et cetera, and antivirals, et cetera, but overall, the response rate was 35.9%, not zero. And then what about the safety? I would just say that there has been no safety signal, which is different than the healthy population for these vaccines in CAR T patients. There has been no known increased incidence of graft versus host disease in these patients. And then these are the box plots. These are CD19 patients of the same pooled analysis, and these are the BCMA patients. These look at seropositivity rates, and each dot here represents the cohort study. So you can see the seropositivity rates anywhere from 10 to about 40. They noted that the BCMA patients had higher response rate, but there are only a few handful of patients. So I'm not sure how to sort of digest this a little bit, but there were responses, and there are other studies that you can look at that look at this in depth. But this is the overall response rate, and it is not different than what we have seen. So what are the correlates of, or what are the predictors of COVID vaccine response in these patients? So this is just a review that was analyzed the SARS-CoV-2 vaccine responses in CAR T patients, and they looked at the predictors of response. Increased lymphodepletion, obviously, prior to CAR T correlates to decreased immune response to COVID vaccine. BCMA versus CD19 is being looked at. In BCMA, there is more severe B-cell aplasia. So the thought is that they're less likely to respond, but we saw it otherwise. So the data would, once more data becomes available, we will know. Increased exposure to steroids or low median IgG levels correlates to poor immune response, and obviously B and T cell lymphopenia. And these is based on serological responses. And so you have to be thoughtful about when I'm talking about this. This review is based on serological responses. And they also saw that Moderna had better responses compared to Pfizer. And they thought is because the interval was a little bit different, and perhaps there was more spike protein amount in Moderna. That's why the immune response in CAR T patients with Moderna was better compared to the Pfizer vaccine. But all is not doom and gloom. What is the best thing that has come out of these studies is the knowledge that humoral responses are not the only one that need to be factored in when we think about protection obtained from vaccines. There are also T cell responses as well. And so this is a very nicely done paper. I would not go in the very depth of it, but I'll just touch the highlights here. This is done in 8 patients with a median age of 18. I think this is also Seattle. And they looked at prospectively immune responses specific to SARS-CoV-2 vaccine in these 8 individual post-CAR T. Interestingly, they did not see any humoral response. And they looked at humoral responses and T cell responses at 0, 1, 2, and 3. And then by the second vaccine, the T cell responses were already being shown compared to healthy individuals. Now, know that they did not see any spike protein increase, but they did see beautiful T cell responses, specifically in CD4 cells. which is important for us for vaccine protection. So on the right side, you have the CAR T patients, and on the left, you have healthy volunteers. And they saw that they had less pronounced, but there were helper T responses because there were more responses in CD8 positive cells. So the conclusion here is that you can't think about response to vaccine just solely thinking about humoral responses or antibody titers. There is more to a vaccine. Now, I cannot claim that for all the vaccines, still it is done prospectively, because one can argue that this is mRNA vaccine and the other platforms of the vaccines of interest that we talked about are different. Nonetheless, we do know that there are responses to T cell. We should look at T cell immunity or immunoprotection, which we haven't looked before SARS-CoV-2. So, going back to our question, why do we need to vaccinate patients for after CAR T? Because they live long enough, and they do experience infections that can be prevented by vaccines. And we decided that the vaccines that we needed, we do think the vaccines will work. But the question becomes, when is their most optimal time? There is some unpublished data that timing post-CAR T anywhere between 3 to 6 months would not matter. But we also know that the presence of B cell or aplasia or having low T cells does not mean that one would not respond to the vaccine. This is all SARS-CoV-2 related vaccine information, but we can extrapolate to perhaps other vaccines. The data does not exist if we can, if you were to acquire these vaccine strategies, would that prevent morbidity or mortality? So these are some of the disclaimers, considerations, thoughts that I have for post-CAR T immunizations. We should know the history of previous history of COVID vaccines, but I'm not sure that would be important for other vaccines, as we discussed. Whether we should do fixed timings or immune reconstitution-based individualized approach to start the vaccine series. We do know that we would prefer the vaccine that have more immunogenicity. Should we check pre-vaccine antibody titers or post-series titers or post-vaccine titers to look at the responses, to look at the durability of response? I don't think we know the clear answer to that yet. And should we develop, we should at least try to develop correlates of vaccine immunogenicity as we move along and advance the field. There is a very nicely done paper by Joshua Hill and colleagues that looked at pre-CAR T vaccines and post-CAR T vaccines. They did it for influenza. They gave them before the CAR T and looked at responses or preserved immunity. So there's that thought process, perhaps much like solid organ transplant, perhaps giving some vaccines before CAR T might be beneficial. So these are the proposed guidelines that were just published by Miguel and another colleague in BMT, and this is the proposed guideline. This is a upgrade or sort of modification of Joshua Hill's and Susan So's proposed vaccination guidance that was published, I think, a while ago, 2020 or 2018, I can't remember now. So I not going to comment about the SARS-CoV-2 because that might change, but obviously we always started post-CAR SARS-CoV-2 vaccine at 3 months. We should consider influenza vaccine before CAR T and then after, depending on the seasonality. These particular authors suggest that we should check titers pre-vaccine series at 6 months, start the series at 6 months, and then should check titers after each after each vaccine to decide whether we are going to continue the series or not. Now, this is just expert opinion that has not been studied very well, that whether we can stop the series if we are at a certain level, because I think that would interfere with the durability of response in these CAR-T patients. So you have the Prevnar, and then you have the pneumococcal polysaccharide, Tdap, Haemophilus, and then hepatitis A and B. So this is the proposed guidance, and this is what we're starting to do at our institution. Very similar to that, but what we are not doing is trying to check titers after each vaccine and thinking about doing the whole series and checking post-vaccine titers. And obviously, perhaps there is something about whether we should do T-cell response studies or look at the durability of response maybe a year after the series or 6 months after the series. But this is the proposed guidance for our institution. I can take a pause if you guys have any questions or you want to look at it for a second. Okay, I'll go on. And I really didn't change anything about the vaccine schedule for COVID-19.
I'm sorry, I have a question. May I interrupt? So sorry, since this is, we know each other. So the point that you made about checking the titers here, is this different for CAR-T treatment compared with the other types of the transplant that you need to revaccinate after transplant?
Yes, it is very different. So the guidelines
checking the titers was what I was trying to get. Like, you're checking the titers for others, but you're not willing to check the titers for this one. Did I get it right?
So so I think you have to repeat your question, please. I'm sorry, I didn't get that.
Sorry about it. So what I understand from your presentation is you're not really supporting, or you're not doing the titer check after the vaccines. Is that correct, or did I get it wrong?
So what we don't want to do is we want to complete the series. So we don't want to check titers after every vaccine shot in the series.
Okay.
And we want to do pre and post, because we don't know that what would be the effect on the durability of the response, and how would that affect the T-cell responses, because it's been extrapolated for CAR-T patients that T-cell responses perhaps start to generate after the second shot. So what we want to take into account the T-cell responses as well, and do not want to affect the durability of response, because this hasn't been studied. Now, I could be wrong, and as we study it more, one would say, if you check serology, everything is preserved, don't do anything, or check serology after one vaccine, if it is, which it is proposed, after one vaccine shot, if it is immunoprotective, then stop the series. And perhaps certain places do that, but that is my opinion, and that's what we are trying to implement at our institution.
Okay.
Did I answer that okay?
I don't want to take more time.
We'll get to questions. I'm stopping. I'm almost finishing, so we have time for questions, because I know that this is my summary slide. So summary slide, which vaccines are important post-CAR-T: SARS-CoV-2, influenza, pertussis, Hep A and B, and Haemophilus influenza. Timing, optimal timing for initiation is anywhere between 6 to 12 months is your sweet spot. I think that 6 months is good. We may have to revisit that after we implement that and see that nobody is responding. We may have to push it. We don't know. But CAR-T data based off SARS-CoV-2 vaccine, we started at 3 months. So I think that this time would be evolved, and sooner is better, is what is thought, rather than later. Because severe hypogammaglobulinemia or B-cell aplasia does not preclude antibody responses, and we have to take in consideration both B and T cell responses. We are going to check pre and post vaccination series titer. And if somebody has the money and then the insurance company space, I think it's okay to check after every vaccine. But we wanted to take cost into account as well. And obviously we need prospective studies to better understand these vaccines and CAR-T recipients. I will stop there. That is my presentation. And I think it's a great time to chat and just discuss some of the concepts that I just presented here.
Thank you so much for that great talk. We can open up the floor to questions. I have some if there are not any immediate.
I just have a question. Hi, Zainab. Great talk. Nice to see you. I just wanted to know, like, so I guess where you said hypogammaglobulinemia and B-cell aplasia, very common after CAR T-cell, of course, so it does not preclude, we should not use that as, you should not use that to gauge, like whether or not to vaccinate and timing of vaccination. So basically that means that we should not look for markers of immune reconstitution, which are followed per protocol. Because, there were some previous recommendations which did comment on that, right? Like to follow those markers and to time the vaccines based on those.
So I think that what we're realizing from SARS-CoV-2 data that you may have them, not necessarily you don't have to check them. You check and see how people are reconstitution because you're basing your prophy off of that for mostly PJP and acyclovir, et cetera. But I think that what we shouldn't do, because there are going to be people who are not going to reconstitute for 18 months or 2 years. And is it wise that for us to think about not vaccinating them at all, which has been the practice, now what we know because of SARS-CoV-2 experience? Perhaps if I had done the talk pre-COVID, I would said, oh, don't do, what's the point? But I think that has allowed us to change our perception about vaccines. Now I could be wrong, and it's peculiar to mRNA platform. But as we know that the platform of the vaccines are continuing to change, they're more moving towards adjuvants and more immunogenic vaccines to begin with. So I think that this is evolving. I'm sharing the MSK experience, our inner consensus. Actually, we are just doing it at our institution. What I presented is what we're trying to implement at our institution. So there is going to be more about what is the best timing and what are the best correlates of protection, which we don't know yet.
Right, that's super interesting. Like, so when you do check titers, like what all do you check for? Obviously, there are a gazillion titers out there. None of them have standardized cutoffs. So which all do you guys check for? And then how do you revaccinate, like based on those?
So that's a very interesting question. So we just had this discussion last week amongst us, and as you know that there is no guidance, but I think that we were extrapolating from some of the other immunocompromised states that because they're moving further away, and if you're really thinking that they're not responding because of B-cell or aplasia, then we should repeat the vaccine series. And if they don't respond, then they don't respond. Now, in our institution, immunoglobulins are not given routinely. So you have to keep that in mind when you're checking these serologies. We don't do IVIG unless there is an indication with severe and recurrent infections. So I have to keep that in mind based on the institution. So can I ask, I know not everybody's on screen, but I was just very, very curious, and I had created a poll. I wasn't able to launch it. How many folks starts at 6 months? Great. And 12 months? No. And not at all. So I guess everybody is vaccinating post-CAR-T now. Okay. And do you base timing at all about with reconstitution? Yes or no? No. Okay.
Yeah.
The other question I had, do you guys check pre and post vaccine titers at all, or post vaccine series titers at all?
Just because there's no standardized cutoff, so we wouldn't know how to interpret the what does it mean? Which brings me to your next question, Zainab. Thanks for the talk. How do you, when you said non-responders, how do you define, is it a clinical non-responder? What is that definition that your group uses?
So we have internal guidelines as what we call responders. It's the increase, how many folds do you rise from the baseline, and what particular test that we use, and what are the manufacturer's thresholds for serocorrelates of immunoprotection. So, area under the curve for these folks is already developed, and these serologies are being used pretty much. I think that what we run into the most issues is pneumococcal, because some are positive, some are, there's an issue there. But these are internal guidelines. We not only look at rise, fold, and increase, and we also look at, have you reached the threshold or not? So each individual serology is different, threshold is different for each particular titer,
And which vaccine are you using for pneumococcus? Is it Prevnar 20 or what?
15, but I think we'll move to
15?
20. I think we'll move to 20 soon, but not yet.
And then even with the 20, you will still give the pneumococcal, right? PPSC 23, because that's what we're doing.
Yes.
Okay.
Yes. Yeah. So I guess
sorry. Regarding the polysaccharide vaccine, how many times do you repeat it? Like you repeat after 5 years and then you stop?
For the non-responders?
For anyone. I think with the polysaccharide vaccine, it is a mess, right? The ACIP CDC guidelines, the tables are as complicated as the COVID-19 vaccines. And then we really do not know what to do after giving the polysaccharide vaccine once. If the immunosuppression is going on, in theory, you have to repeat it after 5 years. That is the second polysaccharide dose, but you don't know what to do after that second dose. Given that our patients will live longer, 10 years after the first dose, I'm sure you have those patients. Do you just give a third dose, or do you just leave it there?
I think unless they're having infections, recurrent infections, is you really just, I don't think that they're repeated after the second. I have to confirm, but I do not know if we have survivals post 10 years yet. Maybe 5, right? And so I think that we'll get there soon, but I don't know the answer to that.
And the questions that you asked, they were about the COVID-19 vaccine and flu vaccine, not live vaccines, right? You don't.
No, none of these are live. Yeah. So there are some guidance, internal guidance, how to approach them, because some folks relapse, after HCT, and they haven't had their live vaccine phase yet. So how to approach that, et cetera, et cetera. But I think if we can do these 4, 5 vaccine, 5 pathogen specific upfront, I think that would go a long way. In morbidity, at least.
Yeah, I think we are kind of lucky, I think, with the pathogens that you listed, because we have some correlative protection for some of them. For example, pneumococci, Haemophilus influenzae, and tetanus, pertussis, you could kind of have some data and a correlative protection, but with SARS-CoV-2, I don't think we have anything. It's tough when you don't have the correlative protection, even for the healthy individual. It is hard to use that information for our patients. That was a great talk. Thank you.
Thank you. I think that there is some data evolving for correlates. I think it will be published soon as to what titer of anti-spike protein correlates with the neutralizing antibody titer at a specific level, et cetera. So I think it's going to come. I think COVID was very helpful in trying to relook the vaccines a little bit and how we approached it. I did want to ask one more question, because I think I want to sort of take away from this group as well and bring it back to our group as we implement this. Would you stop the primary series if the disease relapses?
That's a good question. My sense would be maybe yes, since they will probably once again immunocompromised and not responding to those vaccines. Are probably not worth it, But it'd be great to hear what others think.
That was a great talk, Zainab. I think it might depend what kind of treatment they're getting for their relapse disease if they're getting like rituximab, for example, versus a more milder chemo. A lot of the myeloma patients, we have a big myeloma program here, they do relapse to some degree and need more chemotherapy, and I don't think we stop the series. I had a couple questions for you. One, I just wanted to clarify when you're checking titers prior to vaccination, if patients have some level of seroprotection based on what the manufacturer standard is, do you still go ahead and give the series? I just wanted to clarify that point in your vaccine schedule, if they're showing seroprotection. My other question was if you, I think it's so interesting the differences in vaccine immunity between the recipients of the BCMA CAR T therapies versus the CD19 CAR T therapies, and also differences in immunoconstitution. I was wondering if you distinguish those two groups at all when you're vaccinating them after transplant.
So the first question is, do we go ahead and vaccinate individuals? I think the practice has been very variable for us, because it was not part of like immunization clinic wasn't very much aligned. So the practice has been anywhere. As a first step towards it, we want to see how many, what happens to the IV. So it's hard to know what's the right thing to do, whether we're to say that you're protected and you shouldn't get it, because we know that after the nadir of the hypogammaglobulinemia can occur at a later stage for certain individuals. So to be honest, I do not know what the right thing to do is, but so far, what has been the practice, it's been variable, and people have said to be deemed immune protection and not given the vaccine. But there has been no true guidelines, and I think that's an important discussion. I'd love to hear everybody's thoughts, how you approach it. And the second question, in terms of approaching them with vaccines, we do not differentiate between BCMA and CAR T in terms of timing of initiation or series or anything. How about you guys?
Well, you know, like you said, we routinely give IVIG for hypogamma here, and so they end up getting IVIG for a very long time, and so vaccines are not started until much later in the myeloma patients. They don't do that routinely in the patients getting the CD19 CAR T therapy, the lymphoid malignans.
Yeah.
Go ahead.
I just wanted to say that was an excellent talk, and really, like, I actually learned a lot, and it was really great. And it's sort of an area I'm not incredibly familiar with. The sort of areas about sort of checking serology, right? I think it's sort of always, it's a really important topic. I think that in some ways, sort of SARS-CoV-2 is a little bit of a different situation than the other sort of pathogens that you were talking about, and you were mentioning sort of how much we're learning about checking those things and what are the correlates of immunity, in particular with neutralization assays. You know, the problem with SARS-CoV-2 at this point is that the rate of mutation is so much faster than all of these viruses, and these correlates keep changing with the mutations. And in some ways, like, what we're learning about it may or may not be necessarily applicable to the other pathogens that you were mentioning. You know, obviously, you know, we're not recommending checking serologies for SARS-CoV-2, anti-spike or whatever, you know, sort of as a measure of vaccine response. I think that literature, although it was controversial in late 21, I mean, I think it became clear that, you know, patients with even robust antibody levels had breakthrough and even severe disease, right? So it becomes problematic to use just one single arm of the immune system as a correlate of immunity, like you were mentioning. And perhaps for more stable infections, like more organisms like hepatitis B, hepatitis A, that might be an easier proposition, but certainly with sort of dynamic viruses, it's much harder. And I think that I just wanted to see that that's what you were doing there. You're not, are you checking anti-spike antibodies to see? No, right?
No. Okay. So, you know, that's what I wanted to show you, that for the decision to vaccinate for SARS-CoV-2, we're not. Those are the other mostly encapsulated, and hepatitis we are to see response to vaccine. So I think eventually RSV, as you know, that they just reported the 84% efficacy today with RSV, which is also an mRNA vaccine. So I think RSV, flu, and SARS-CoV-2 are going to become like seasonal vaccines eventually. So I don't know the answer. Maybe I just think a little bit like that's how it's going to be, but I could be wrong. But I think
Yeah.
that for these seasonal, I don't think serologies are only meant for pneumococcus, diphtheria, Haemophilus, hepatitis, etc. So
That's great. I have another question for you. So we struggled a little bit. Maybe this is more relevant for a few months ago when the bivalent booster was sort of maybe thought to be a little bit more protective for these newer strains than it is. So we had CAR T cells, and the team came to us to ask, all right, so we generally vaccinate with the primary series. So given what we know about the primary series of SARS-CoV-2 is sort of using the original virus, and only at a later stage you get the bivalent booster. So they were asking us whether it was sort of, do we start this process and only get the bivalent 6 months later, right? Or even later, or just give them one bivalent booster at that time, assuming that they had some underlying immunity already. How did you guys navigate that issue? And was it posed to you? Did they ask you that question? And what would you have answered?
So I think we went a little bit, that came up, the excellent question. Yeah. And so it was like, should we just do the primary series with bivalent? Like, that's not even a thing yet, right? But what, you know, right. You just got thinking about how to best protect them. And I think we're waiting for some data. So so SARS-CoV-2, you know, we leave it IP to sort of change that as the data becomes available. So we're sitting on it because with the anticipation that that would change, and you know, perhaps bivalent will become the upfront series. I don't know the answer to that. We've been waiting on this data for about 2 months now. So yeah, it came up, but I don't know what's the right thing to do. I completely agree. Like, when we know that this is better, but why are we still doing this? Yeah, I don't. You know, but the issue is that we have to stick within the boundaries.
Yeah,
that's the hard part. So, yeah.
I have one question if you have a minute. You mentioned a lot about, like, we don't have a lot of data on serologic responses to non-SARS-CoV-2 vaccines in these patients. And like, you know, I think there are some obvious barriers to that sort of research, but do you have any thoughts on how we might overcome that, or maybe best approaches to getting that data?
So I think that as we implement these programs, I think it would be very important to check serologies as much as, you know, cost. Obviously, we have to keep that cost in mind. So pre and post makes sense because it's important for us to tell our patients, and these are informed decisions. Obviously, checking after every you know, vaccine, it would be more research based. So when we're doing these clinical implementations, we want to be mindful. So there is one actually report that looks at pneumococcal vaccine, and it said that before 6 months, if you give it, they don't respond, but it's a very strangely done study, et cetera, et cetera. It was retrospective, and then trying to look at prospectively. So I didn't even comment on that. So I think that in implementing serologies and moving forward as we implement would be the best way to go with it. Yeah, I think that it's definitely an interesting and evolving field.
For sure.
It's going to be really exciting to see all the literature coming out, right? I mean, obviously, it's a new world of checking for vaccine response, and the data that we learned with COVID-19, I think it's going to be fascinating how that applies to the other vaccines. We're already talking about, for our solid organ transplant recipients, what kind of measurements can we have to make sure that they're responding to their vaccines post-transplant, you know? And I think we'll see that with influenza, like you mentioned, RSV. It'll be very interesting to see what happens.
So there, I know that there is a platform that has the combined influenza, RSV, and COVID vaccine that is under trial right now. So I think
or what, like a vaccine?
Vaccine, yeah, like a, what is it called, multi-component vaccine. So, you know, it's all coming our way, whether we're ready or not. So which one to pick, what's the best one? It's going to be hard. And then I think correlates of protection would be hard. And what's interesting, we were looking for, I don't know if this is perhaps a good group to ask, we were looking at pneumococcal specific T cell responses to certain antigens. There's nothing available to even look at that. To study, and if you guys know any connections, please do let us know, because we're looking for somebody who can help us with T cell based responses to pneumococcal vaccine. So
I would get in touch with Moonam from UAB. So he's the one who came up with the opsonophagocytic assay for WHO that is used for the licensure.
Mhm.
And they also have serotype specific T and B cell responses. If you would like to connect further, I also have a chemist who's working at Emory. We have a grant together that we are exactly looking at serotype specific CD4, CD8 cells. It is a hard assay. And the reason is, as you pointed out, 19A is not as serotype 3 or 6A. So it is almost like 23 different, well, different antigens. But it's
Please.
possible.
Yeah, if you could let me, you have my email, if you could just send me a blurb, like I would really appreciate that. Thank you.
I will.
Yeah, thank you.
All right, well, our hour is almost up. Thank you so much, Zainab, for talking with us. That was a lovely talk and obviously a very involved discussion, so always successful. All right, thank you so
Thank you,
much.
everybody. It was lovely.
Thank you so much.
Everybody, take care.
Thank
Take
you.
care.
That
Bye
was
bye.
great.
Thank you.
Bye.